Hey everybody, here's a step 1 prep video. Like and subscribe if you want more content. Here we go, dermatology. 8-year-old girl presents with a 3-month history of itchy, dry, red patches on the inner sides of her elbows. And she has a history for allergic rhinitis. She's got the excoriated pink plaques with early lichenification in the antecubital fossa. So which of the following is the most appropriate initial management? So what are you going to give her? Topical corticosteroids. So let's dive into this a bit. So this patient presents with symptoms of atopic dermatitis, so eczema, including pruritic, dry, excoriated plaques with early lichenification of the flexural areas. So that those parts of your body that you kind of like flex a lot, like this one, like your antecubital fossa, are going to be affected here. Her history of allergic rhinitis supports the diagnosis of atopic dermatitis, commonly associated with other symptoms like asthma and allergic rhinitis. So first line treatment, what do? You give them topical corticosteroids. So allergic rhinitis, asthma, what do? You remove the stimulant. You remove the stimulant if it's a type 4 hypersensitivity reaction. So this is actually going to be not with atopic. This is going to be with contact dermatitis. But yes, this is going to be a type 1 hypersensitivity reaction. And there's a type 4 hypersensitivity reaction. That's with contact dermatitis. That's whenever you make contact with something like, I don't know, poison ivy. And that would have linear lesions. And if it does have those things, like they went to a woods and then they went to the woods and came back and they have linear lesions on like their foot, contact dermatitis. But this is atopic dermatitis, eczema, asthma, allergic rhinitis, and you treat this one with topical corticosteroids. The other one you treat it by removing it, giving cold compresses, that kind of stuff. Oral antihistamines provide with some relief, but it doesn't actually address the underlying inflammation or dryness for atopic. Antifungal cream, that would be for tinea corporis. That would have the annular scaly plaques, not the dry pruritic ones. They'd be the really scaly. Oral antibiotics, that would be like the Impetigo, and that's not first line for atopic. Emollients, that'd be for maintaining skin hydration, but again, that's not for atopic, which you'd use the corticosteroids for. Melanocyte nevus, that's just like a mole. And the thing about the mole too is if it's flat, then it's going to be benign and it's going to have a junction, but if it's raised, then it's going to be one of the layers. Flat means it's multiple layers. Psoriasis would have the pericatosis and acanthosis of the stratum spinosum. Rosacea, that's like when you can have the rhinophyma. That's like the nose that is like bulbous, and it's like associated with a lot of vascular problems. So just a couple of random related little factoids in here at the end. The basic idea here is atopic dermatitis has this pruritic psoriatic plaques on the flexural surfaces in children and is associated with these other two, asthma and allergic rhinitis. And you can, do some moisturization, but ultimately you want to use topical corticosteroids. So you got this itchy, dry rash in the elbows, boom, that's going to be the sign. So hopefully this was helpful. If it was, like and subscribe.